Hi, everyone. My name is Cameron Lyons. I'm your instructor for the TMJ content as part of MM3. This is the TMJ imaging supplement that Cameron and I wanted you to see before we got into lecture um, on the 7th, just so you had this information, but we didn't want to spend too much time on it in class. So basically, we can order imaging in Colorado. We don't need images terribly often, but sometimes they're handy. Occasionally, patients are seen by an orthodontist or a dentist who specialize in TMD, and you'll have some imaging that they provide for you. I think about this as a way for us to synthesize some of the objective information that you can get from imaging and how you apply it to the clinical picture in front of you. Think about how posture is related, think about how the cervical spine and the jaw are related, and think about how that might change how things move, especially in terms of muscle function. And so on the screen, you can see kind of a drawing of what one would see in a lateral cephalometric plain film. And you can see there's different markings over here on the image. And I wanted to walk through those so you can see how you might objectively assess cervical lordosis, cervical and mandibular postural relationships, and even kind of the positioning, if you will, or the posture, if you will, of the suboccipital space. So to start with, we'll draw the odontoid plane. So this is a line that goes through the peak of the dens, through the kind of anterior inferior point of the dens, or I guess you maybe say the body of C2. So it's not really a vertical line, but it's a straight line that has kind of a vertical orientation to it. Then you have MGP. This is McGregor's plane. It's just a line through the nasal sinus. So the spine of the nasal sinus is that structure there. You can see that really readily on an actual film, which you'll see in a few slides. Just extend a line from there straight back through the bottom of the occiput. And those two lines together give you this angle marked as 1, which is the craniovertebral angle. So it gives you an idea of the cranium and upper cervical relationship. The next important imaging landmarks to look at are down here. And it's this inframandibular triangle, which is really a line from the anterior inferior angle of C3 over to the mandibular symphysis, and then down to the hyoid, and then back to that same point on C3. And that gives you an idea of kind of mandibular and lower cervical posture and positioning. Can also give you a good idea of the inframandibular hyoid related muscles and where they're at in terms of length and tension on those muscles. We typically look at films from posterior to anterior, whereas a dental professional would go from the front back. There's other stuff here with certain teeth that they look at, which we don't have much business with. So our perspective is from back to front. And we can also see the spacing between the occiput, arch of C1, and the spinous process of C2. And that gives us the functional spaces in the suboccipital region, which should be about 6.5 millimeters between each of those bones, so these actual spaces. And the thickness of the arch of atlas is about 7 millimeters. So if you add all three of those up, you get something that's right about 20 millimeters of space between the occiput and the spinous process of C2, which is palpable. You can feel that too, and get an idea for how much space is there based on whether there's one fingertip worth of space or slightly more than that. We talked about how to find and define this angle. Normal is 101 degrees plus or minus 5. So it allows for a little postural variance. But you know, if it's more than 5 degrees off, either above or below, that's not normal. Here is an actual film. I dropped a few lines on here so you can see where we're at. So again, if you look from back to front, suboccipital spaces here look pretty good. Those spaces look like they're fairly well maintained. And then if you draw McGregor's plane in there from the occiput to the spine of the nasal sinus and then back, and then drop the odontoid plane in, the angle here, if you were to kind of ignore the picture on it and just kind of look at these red lines, how they intersect, it's pretty close to 90, which is obviously less than we would expect or want. And then if you come down here, this looks funny, doesn't it? Because if you go from C3 back up to the hyoid and back, you end up with a triangle that's not quite how it should be. It's inverted. If we go back here, you can see the point of that triangle is supposed to point downward, whereas here it's pointing upward. And again, here, if you look at the body of the vertebrae of the cervical spine, they're all kind of anterior to this line that comes down right behind the hyoid. Whereas here, if you hyoid, odontoid, that's what I meant, I'm sorry. But if you come back through the odontoid here, you can see that some of those vertebral bodies are in front of that imaginary line, but some are behind. And you can see how flat the cervical spine looks. And you can see how little lordosis there is. In fact, maybe if you squint enough, you can almost see maybe almost like a reversal of the lordosis there. Typically, with a normal cervical spine series, you'll get an odontoid view, and that gives you a good view of C1 related to C2, and this can give you an idea of where their maxilla and mandible should be, and you get a good idea of the relationship between the dens and C2 and C3 and C1 and their relationship to one another, which can point towards some upper cervical dysfunction if you see things that aren't quite right. So you should see pretty even spaces between the dens and the lateral mass of C1. And same thing here. There should be pretty even spaces between the lateral mass of C1 and kind of what we call the shoulders of Atlas. And what you're looking for also is that the dens in C2 and the spinous process of C2 are pretty well aligned vertically. If they're not, if say C2, the spinous process of C2 was over here, that would suggest that C2 is rotated in the transverse plane. Because obviously it's part of the same bone, so they can't really be disconnected without some sort of major trauma fracturing. But if C2 is kind of rotated to one side or the other in space, the spinous process is going to look like it swings around this way or swings around that way. And that can be an obvious indication of what might need to be treated as far as upper cervical function goes. And here you can see there's asymmetric spacing between C1 and 2 around the dens. And so C1 is not sitting evenly on top of C2. And so that's another suggestion that this is rotated toward the left in this case, and then there might be some upper cervical work that needs to be done to help with upper cervical function. This is probably a case where this patient's having headaches, although not guaranteed, but probable, and could be leading to some craniomandibular dysfunction too. So when it comes time to imaging the TMJ itself, this is a lot like other imaging in the spine, where there's a lot of of disagreement between what normal is and what normal isn't, and the fact there's a lot of changes in the spine that occur over time that are really considered normal, although come up as a positive finding on imaging. We've seen this a lot in the lumbar spine and the cervical spine, and it's true here for the TMJ itself. So in the dental literature, there's a very specific definition of where the condyle should be centered in the mandibular fossa of the temporal bone, and they call that centric relation. And this study showed that an MRI of asymptomatic people, all with kind of more advanced age, showed that very few of them actually hit that true centric relation. So why that's still considered normal when hardly anybody meets that definition is kind of perplexing to me. I think it's just convention. They've used that definition for decades and decades, and so they keep using it because that's just the way that it's always been. But you can see that very few, 4%, actually met that definition well, and then about half of them got pretty close to a center position. Interestingly, in females, it's actually more common to have the condyle shifted more posterior in the fossa. So maybe that should be the definition of normal for women. But age, gender didn't really seem to have an influence. Genders and age can be positioned kind of any way it might be. And what we're seeing here in their summary from the article was that this positioning isn't really an indicator of abnormal TMJ function, and you can't really rely on imaging alone to treat this. And clinical symptoms and limitation of jaw movement ought to be considered, or maybe the primary considerations for actually treating these patients. This is a different study, but pretty similar conclusions. They used a cone beam CT scan, so really specific, really detailed bony images you get from these. And similarly, they had age-matched groups, but they had an asymptomatic group and a symptomatic group. And you can see these numbers here, as you go down the table, are very similar. And so just because it's there doesn't mean it's a problem. And you can have flattening of the condyle, you could have sclerosis, you could have little cysts, you could have bone spurs. All these things happen, and lots of people have them and never have any symptoms. So this is just another case of you treat the patient, not the CT scan. This is just a kind of a summary slide of what I was just saying, that all of these findings were comparable between the groups, and this type of scan may not be necessary for TMD patients, and the clinical exam and the person in front of you should be what you treat. Okay, well, I hope that was informative, and I hope that jives with what we already know, or what you already know about imaging in the spine. But not to say that these images aren't any good, it's just you need to take them and make them part of your assessment and not the definitive piece of information that drives your treatment. Thanks, guys. We'll talk to you soon.